All right, it is 12:30 here, so we are going to get started. Hello and welcome, everybody. My name is Amy Forbes. I'm the training manager with the Northwest Mental Health Technology Transfer Center, otherwise known as MHTTC. Welcome to today's webinar discussing and documenting sexual orientation and gender identity, or SOGI, with Dana Morrison and Rachel Grime. This is the second of our 4 sessions in our sexual health series. Before we get started, I'm going to go over a few things and give you some brief information about the MHTTC and the AETC, which we are in partnership with for this series. The Mental Health Technology Transfer Center is a nationwide network supported by SAMHSA. Our network includes 10 regional centers and a network coordinating office out of Stanford. And you can see on your screen that pink circle. The Northwest MHTTC covers HHS Region 10, which includes Alaska, Idaho, Oregon, and Washington. Our goals at the Northwest MHTTC are to support mental health-related evidence-based practices, heighten awareness, knowledge, and skills of the behavioral health workforce, foster alliances, and address diversity of training needs, and to share free publicly available training and technical assistance. Our areas of focus include evidence-based practices for psychosis, such as CBTP and ACT. However, we do provide training on a wide variety of other topics. Please do check out our website to register for an upcoming webinar or watch a past recorded webinar. You can register for a learning community, take an online self-paced course, sign up for our weekly newsletter. You can review our resource library and also listen to our podcast. Do need to mention that at the end of this webinar, you will get an evaluation. It's really important. We value your opinions and we would like you to fill it out. We are required by SAMHSA to conduct the survey, yet we do not have they do not have an official position on our content. And with that, I'm going to pass it over to Lori, who's going to give a brief description of the AETC.
Hi, I'm Lori Sila. I'm the director of the Mountain West AIDS Education and Training Center, and we are part of a national network of AIDS education and training centers that are funded by HRSA, the Health Resources Services Administration. We are the training arm of the Ryan White program, which you may have heard of. Ryan White is the primary federal funder of HIV care and service. There are 8 regional AETCs, a national clinical consultation center, which is that UCSF address at the bottom, and there's also a national coordinating resource center. So if you practice outside Region 8 or 10 and want additional HIV-related training, you can contact that AIDS ETC address. We serve regions 8 and 10, which consist of Alaska, Colorado, Idaho, Montana, North and South Dakota, Oregon, Utah, Washington, and Wyoming. Our mission is to deliver innovative education and training to improve access to care and quality of life for people who are living with or who are at increased risk for acquiring HIV. If you visit our website, the mwaetc.org, you could sign up for our monthly newsletter. You can view videos of prior trainings, check out what's coming up on the calendar, access national resources, watch on-demand presentations that have already happened. You can also request a training from us if you are practicing in Region 8 or 10. We do both in-person and online training. We offer clinical consultations. We run ECHO programs, which are virtual communities of practice, one-on-one provider coaching, preceptorships, and we also organize a number of conferences, and all of this is made available for free, and some of our programs also have continuing education available. You can move on.
Thank you so much, Lori. So we'd like to tell you, as I mentioned before, you're attending the second session of our sexual health series. Please register for upcoming events on this series. On June 17th, we'll be having Prep Talk, Enabling Mental Health Professionals to Lead in HIV Prevention. And then July 16th, we'll have the Syndemic of HIV Sexually Transmitted Infections and Behavioral Health Disorders. Oops. Sorry about that. Now for some important information to keep in mind during today's webinar. We'll share a link to the webinar recording, slides, as well as your certificate of attendance within a couple weeks after this event. And please do note that you have two boxes, a chat box and a Q&A box on your screen. Please use the chat box if you need assistance from our staff or you would like to share respectful comments, greetings, or observations with everyone. Then please use the Q&A box at any point throughout the presentation to type questions for our presenter. We will be monitoring the Q&A box to facilitate answering as many questions as possible, either during and or after the presentation. And with that, I would like to welcome and introduce you to today's presenter. We have Dana Morrison, and she also has Rachel Grime, who's going to be helping us with a lot of the chat and Q&A. They're both from the Oregon AETC. Welcome to both of you, and thank you for being here.
Thank you. I'm going to share my screen, and I'm just really honored to be here today and happy to talk with all of you. You're just going to see my screen real quick, but we're going to make magic happen. As said, my name is Dana Morrison, and I have been with the Oregon AETC for over 10 years, but prior to that, I have worked in the field of HIV since 1998. So we're going to start out with a poll, just wondering kind of what is your experience asking SOGI questions, and if you don't know what SOGI stands for, that's fine. Feel free to put a 1 down. I'm going to hide people's faces because I have everyone's faces in front of my screen. But just want to see who's in the room and kind of where folks are at. So 1 is no real experience with sexual orientation, gender identity questions. And 5 is kind of feel like you're an expert in this field and you've been doing a lot of asking of the questions. And I think there's going to be material today for everybody because there's a lot changing and it's a constantly evolving topic. And I really hope that there are things that you can take away to support your clinical practice. I'm going to end the poll just for the interest of time. And we'll share with other folks. So about a fifth of you are kind of brand new to this topic. And then we kind of have a lot of you hovering around the middle, and then a few folks that are experts. If you feel like you have things to add, I definitely want to encourage folks to use the chat and share their experiences. And Rachel and I are going to talk a little bit more about how we work together to make sure that you get your needs met from this training. So with that, I'm going to get started. I have no commercial or financial interest to disclose, and I wouldn't be here without my amazing team of folks that have really helped figure out how best do we share this information and teach this information and really get it adapted into healthcare settings. So I want to bring attention to Rachel, who's on the call today, Alexis, Marty, and Aaron. And I want to start by taking a moment to recognize the unceded ancestral lands of the first people. Today, I'm gathering with you from the lands of the Clackamas, Cowlitz, Cayuse, Umatilla, Walla Walla, Confederated Tribes of the Siletz Indians, and the Confederated Tribes of Grand Ronde. And I want to pay respect to their elders past and present. I also want to acknowledge that economic growth and development throughout history and across time has been made possible by the labor of enslaved people, primarily of African descent, who provide the exploited labor on which this country was and continues to be built. We are indebted to their labor and their sacrifice. I want us to take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. I think it's really important for us to think about our roles and what we bring into this space. And as a cisgender woman and a settler to these lands, I want to recognize the privilege that I bring to this space. I also think that as part of ending new HIV infections, we as a provider community must elevate those groups who have historically and are currently marginalized in our communities and in the response to the HIV epidemic. It is our responsibility to listen, recognize, and bring their experiences to the forefront. And I want to make sure that we go beyond just reading a slide and having an acknowledgement to really reflect on the work that we're going to do in the space today. I want each of you to really think about what privileges have allowed you to be in this space today, to be paid potentially to be here, to come to this training, to learn this information, to have childcare, to be able to work at your job or to make a certain amount of money at your job, to be able to afford to own a home, for example. And then really thinking about what are your intentions that do you have to disrupt and dismantle colonialism beyond just an acknowledgement. And when I'm talking about colonialism, I'm talking about, especially in the context of this presentation, this concept of binary identity actually came over with European expansion to this land. And so the concept of more expansive gender identities far predates the colonialism and expansion. And yet today we are still contributing to erasure of identities by not asking questions in a more expanded context. And I also want you to think about beyond just what you can do, what are the commitments your organization might be willing to make to build more inclusive systems of care for your patients. So today we're going to talk about defining and differentiating sexual orientation, gender, and sex, bringing attention to gender modality, identity, and expression, and really identify how asking questions about sexual orientation, gender, and sex can improve healthcare for the patients and being able to explain that value to others. I also want to make sure that we're describing how stigma operates in our healthcare environments so that we can identify strategies to counter stigma while utilizing affirming language for all of our patients. So your insights and questions are valuable. So I want to make sure that folks are feeling empowered to use the chat. My colleague, Rachel Grime, who also can deliver this content, is in the chat to answer questions in real time because I think folks are going to have questions come up. If there are things that are better for a broader audience, we will probably save those to the Q&A time of this presentation. But in real time, we can have a lot of that discourse happen in the background. So I'm going to keep going through the slides so that we get the content and you get the tools that you can take back to your teams. But please, I encourage you to use the chat and reach out to Rachel, either one-on-one or in the group chat to get your needs met. So what is SOGI? So SOGI refers to sexual orientation, gender identity. And it's really an understanding of sexual orientation as a person's romantic or physical or emotional attraction to other individuals, gender identity, that internal sense of self, and sex is really the language that we use to categorize reproductive biology. That's what we're talking about when we talk about SOGI. You may have heard other terms such as SOGI with an IE at the end. E is adding in gender expression to that kind of laundry list of letters because there's lots of letters in this work. The reason why we don't talk about expression is because we don't collect data on gender expression because people's gender expression might change depending on the setting in which they're at. They might have a way that they express gender in a home environment that is different than a work environment, that is different than a healthcare environment. And so those data aren't something that we collect as part of routine practice. You might also have heard of SOGI with the SC at the end. That's just adding sex characteristics into that. I think regardless of which terminology you're using, today we're going to focus on the SOGI. It's really important, though, to remember that these do not equate to LGBTQ or lesbian, gay, bisexual, trans, or queer questioning identities. SOGI questions are for all people and that everybody has a sexual orientation and gender identity, but most people, about 85% of folks, don't have to think about it because they fall within the dominant culture of heterosexual and cisgender. So why are we collecting SOGI data? We ask these questions, and if you don't take anything else away from this presentation, really thinking about these motivating values, because this is how we convey this to others. But we ask these questions to make sure that we are creating safe, inclusive, and welcoming environments and recognizing the diversity of all the populations that you serve. We want to support health equity efforts and direct people to the group-specific services and distribute resources in a way that people get their needs met. And in a bigger way, we want to shift social norms about and broaden our understanding of who is included and accepted in the populations that we serve. No one got into healthcare to serve people that have the same lived experience of them. It's really we got into healthcare to help all folks. And so what does all folks mean, and how do we make sure that our environments reflect that value? I think there's also some benefits to the individual patient that's important to call out, such as understanding a person's identity and experience will build trust and provide opportunities to really connect that person with the best available resources. We can validate identities and create supportive environments by offering opportunities for individuals to share their true or their authentic selves. And asking SOGI questions in a routine way can indicate that this is a safe place for that person to access services. I think it's really important as we're having these conversations to also recognize that we as providers are also patients ourselves. And by creating a safe space through our forms or our intakes or the way that we talk to patients, we're also creating a safe space for staff to live their authentic selves and feel included in their healthcare environment and in the environment in which they're working. At a system level, we really are asking questions to address bias and stigma by normalizing all identities and creating space for everyone in the populations we serve to be seen and heard. We're helping providers serve the needs of their communities in the widest sense with respect to sexual orientation, gender, and sex, and are really able to better estimate the magnitude of health inequities in our practice setting and at a broader scale. We are able to identify potentially beneficial policy interventions that will aim to reduce those inequities and really assess the effectiveness of the work that we're doing. So I want to start with a brief history. And really, this slide comes from Alexis Dino, who is a professor at Portland State University. But really, she says these are the bad old days, really understanding that we have been collecting data on SOGI, or sexual orientation, gender identity elements, for all time. We as a society have been categorizing people into boxes on forms since we've been collecting data. So this is not a new concept. I think it's important to point out, though, that the data were collected in a way that was based on a lot of stigmatizing assumptions, historically speaking. And so really wanting to understand that while we might have been asking or having space for people to be put into boxes on our forms and different things, that really there were some stigmatizing assumptions that were behind the way data historically has been collected. And that's really bringing attention that only masculine and feminine genders matter. So for example, what is your gender? Male, female, without any space for other options. And we also often see sex and gender conflated in the question, where you might have a question that says, what is your gender? But it asks, the response options are female and male, which are sex characteristics, whereas woman and man are gender categories. So really understanding, and we'll talk more about this, the different language that we use, where sex categories are female and male, gender categories are woman and man. And yet oftentimes our questions conflate those two concepts. There's also an assumption that everyone is straight, monogamous, or has some sort of marital status, and that transgender experience does not matter and is not usually captured. Intersex is also something that we have not historically captured in our documents, and that leads to erasure of identity. And really, there's been this underlying assumption that anything outside of what is listed on the form is aberrational or should be pathologized. More recently, I think there's been a movement, and for those of you familiar with the Behavioral Risk Factor Surveillance System, or BIRFIS, we collected some data prior to 2010 that asked about lesbian, gay, and bisexual identities. Gender on the BIRFIS at that time was assumed based off of the sound of your voice, so that data is not considered complete. But when it came to metrics related to health, Healthy People 2020 goals said, oh, we forgot lesbian, gay, and bisexual identities. So they added an addendum of metrics in 2010. So this preceded the 2011 Institute of Medicine and Joint Commission reports that really pushed health systems to create not only better understanding, but also policies, practices, and procedures that allowed for folks to identify family of choice at the time of medical crisis, for example. It's also important to note that until the Institute of Medicine report, the NIH, or the National Institutes of Health, did not fund research on LGBTQ plus identities, as that was the foundational report that led to the integration of that as a priority area for NIH funding. And all of this laid a foundation for those of you who work in federally qualified health centers. You might be familiar with the Uniform Data System, or UDS. UDS is required data elements for FQHCs by HRSA, or the Health Resources and Services Administration. And so these are the current UDS questions, but these are requirement of funding for all FQHCs. And so these are questions that are currently being asked by your federal funders. And so you might see these in your systems, and they are a step in the right direction. But there are ways that these questions can contribute to erasure, and that's what we're going to talk about today. I do want to point out, so right now for sexual orientation, if someone lists something other than lesbian or gay, straight, or bisexual, they are considered missing data in the federal data set. So something else, don't know, or choose not to disclose are not included and are considering missing data, even if someone were to write in a different answer. As for gender questions on the Uniform Data System, Male, female, transgender male, and transgender female are also the only identities that are in the federal data set. So if someone were to write in non-binary, which is a recognized identity in 22 states, the District of Columbia, and federally, they would not be included in the federal data set. Using those questions, though, there was a Gallup poll that came out in 2021. I want to point out that this was a telephone-based survey. So you had someone calling you on the phone asking you about your sexual orientation, gender identity. So we assume that not everyone's going to answer that question. But of those that answered a random stranger asking these questions, about 7% of the US population identified as something other than straight or heterosexual. Through qualitative research and other studies, we know it to be closer to 15%. But in this study, what I think is important to point out, of those who listed something other than straight and heterosexual, almost 57% listed bisexual as their identity. And as mental health providers, I think it's really important to recognize the power that community has in overall health and well-being. And there is kind of recognized lesbian and gay community, but there's not the same community mobilization around bisexual identities. And a lot of folks who might identify as bisexual could be living in heteronormative relationships. And we're going to get into some of these terms I'm using later. So if I'm going too fast, don't worry, we're going to slow down and do some definitions. But I did just want to bring the attention to the fact of how many folks actually identify as bisexual who may not be captured with our existing data collection methods. The other thing I liked about this Gallup poll that I want to bring attention to is people's safety around disclosure. So this looked at people's age or the generation asking the question and how many people identified as something other than straight or heterosexual. And I think it's important to note that we are not getting gayer as time goes on. I promise that's not the case. But people are feeling safer to disclose identities that are different than the dominant culture. And so that's why you see people born between 1997 and 2003, almost 21% of folks identified as LGBT, as compared to the traditionalists that were born before 1946. This doesn't mean we shouldn't ask questions of all age groups, because we want to create a space for everybody to feel included and safe. But it does mean you might get more folks who don't want to answer the question or don't feel comfortable with the question. So we ask of everybody, but it's okay to leave it blank, especially if folks are coming from a space where they don't necessarily feel safe disclosing. Which brings us to really understanding stigma. And I am not going to take all my time to talk about stigma, but I think it's really important for us to think about the way that stigma operates in the world that we work. And so you have like the structural level, which are our rules or our policies or our practices or procedures or the literal structures of the space in which we work that can cause harm by excluding folks that can't access the services as equally. Interpersonal is really where implicit bias shows up, and that's our person-to-person interactions that we have, as compared to internalized stigma or the kind of internal debate that goes on within myself of, do I belong in this space? Is this the right place for me? And so I think thinking about how stigma plays a role in that comfort around disclosure is really important. And I really want to note that I'm using the term stigmatization as really as synonymous with discrimination and that impact that stigma can have on people's ability to interact with the world. And so I think it's important for us to just think about that. If you want more information, I put some of these articles in. This is references from Alexis to really think about how stigma is really impacting healthcare environments in a broader sense. When we look specifically at LGBT stigma in healthcare, this is from the Center for American Progress. This is a study that looked at had people experienced discrimination in the last year. And that's not to say that any one of you has ever discriminated against someone in your healthcare setting, but I think it's really important to know that people are coming into your space having experienced an adverse event in the past. And especially if it's in the past year, we know it has a bigger impact on people's ability to access services. So this looked at across the board, about 1/3 of LGBTQ Americans had experienced some form of discrimination in the last year. But when we break it down, we see that that number is highest among transgender individuals, 62%, and even higher still among non-binary, genderqueer, agender, or gender nonconforming folks. Approaching 70% of folks had an adverse experience in a healthcare environment in the last year. And what did that discrimination look like? I think it's really important to, like, when we're talking about discrimination in a healthcare setting, what are we talking about? We're talking about a doctor or provider being visibly uncomfortable due to actual or perceived sexual orientation, a provider using harsh or abusive language or blaming someone for their healthcare status, doctors or providers intentionally refusing to recognize family members And I think what's also disturbing is more than 7% of folks had experienced unwanted physical contact with a healthcare provider in the last year. And so what does this translate to, right? And so it translates to a fear of healthcare environments for the LGBTQ plus community, where about 15% of all folks report postponing needed medical care due to a fear of discrimination, and it was about 30% of transgender individuals. And I think it gets much worse when we look at preventative services. So while it was 16% overall, it was 40% of transgender respondents reported postponing or avoiding any preventative screenings due to discrimination. And so I think it's just important that this is in our mind, that this is real. People are experiencing this, and we need to be prepared to create a space that offers something different. I also wanted to bring attention to the 2022 U.S. Trans Health Survey. This came out in January of 2024, because I also want to just reflect that when people are accessing services and living their lives as their authentic self, they have an overall better quality of life. So this survey had over 90,000 U.S. participants, and nearly all reported who lived at least some part of their time as a different gender reported more satisfaction with life. About 79% were a lot more satisfied, and about 15% were a little bit more satisfied. And those who received hormone treatment and gender-affirming care, 98% were more satisfied with their life. So accessing care is life-saving care, and we need to be really mindful that we are not creating unnecessary barriers through our systems or our structures, and so that people can feel safe in our environments. I think it's also important to recognize that healthcare doesn't happen in a vacuum, and there's a political environment going on in the United States that is really scary for transgender individuals. 47% of adult respondents in this survey had thought about moving to another state because their state government had considered or passed laws that target transgender people for unequal treatment. There were over 600 state bills last year targeting transgender individuals, and about 550 bills have already been put forth in this current legislative session of 2024. These bills really are attacking people's personhood and right to exist in their states or use a bathroom. About 5% of individuals who took the survey in 2022 had moved out of state because of laws. And so depending on where you're located, you might be seeing an influx of transgender individuals who are moving in the current political environment to your space and then trying to access care. So take a breath, feel free. I just went through history really fast. And I'm going to go through some definitions. I'm not going to read every definition, but you will get the slides as a PDF so that you can access this and kind of spend some time with the definitions. But I think there's some terms that might be new to you in thinking about sexual orientation and gender identity. So as we get started, I'm going to start a video because I think you don't want to just hear my voice. And then we'll kind of get into a little bit more detail.
Sexual orientation is one of the most fascinating aspects of our existence, and that is because sexual thoughts and attractions are experienced inside our minds. Every individual's sexual orientation is a bit different from the other, just like personalities and appearances are slightly different in each person. Different people are attracted romantically or sexually to various features and characteristics in others. Some people do not feel attraction at all and identify as asexual. A person's feelings about attraction can evolve or may stay the same over time. The same is true across cultures and countries all over the world.
From when I was a small child, I remember myself falling in love with boys. Although, from time to time in my dreams, I would be fascinated by a beautiful woman or feel something from imagining a woman. Now, I never found myself attracted to a real-life woman standing in front of me, so I consider myself straight.
From a very early age, I experienced this feeling that would later become attraction towards men. For years, I was so afraid of dealing with my sexual orientation, until at the age of 21, I hooked up with a woman. And that made me realize finally that women are just not my cup of tea. So from then on, I started a process of accepting my feelings and coming out as gay to my family and friends.
I would probably define myself as pansexual. I'm more drawn to the soul and character and less to a specific gender. I had relationships with all genders, as each of them met a different emotional need of mine. And for the past 3 years, I've been living with an amazing woman who I'm still madly in love with.
As you can see, there is a wide variety of sexual orientations. Human sexual orientation is a spectrum. As we open our minds further, we learn to respect and accept the differences in each other, and realize that love and attraction may come in many forms.
You don't get to watch it twice. Sorry about that. You might want to, and you'll have the link later to watch it with your team and colleagues. This is a model for thinking about sexual orientation, gender identity, modality, expression, and sex. And so this is a model that we kind of have modified over time. And so I want to bring attention to the colors of this model because you'll see that throughout the rest of the slides. So where you see this green color, and I know that they're not drastically different, but where you see this green color, that's where we're really talking about sexual orientation. So that's, again, romantic, physical, emotional attraction to other folks. Terms you might hear related to sexual orientation are heterosexual, lesbian, gay, bisexual, queer, asexual, questioning. Gender identity is this peach color. Or gender is this peach color where we start with identity, which is a person's internal sense of self. That's where you might be a woman, man, non-binary, gender queer. Gender modality is a person's experience of gender, and we're going to spend more time on that, which is transgender, cisgender, or questioning. Gender expression is really how the world might see you. And then sex really is focused on that biological reproductive anatomy. So some terms that might be new to you that I just want to bring attention to are same gender loving or same sex loving, which is refers to attraction to people of the same sex or gender. It's important to note that this was coined for African American use by Cleo Manago in the early 1990s as a description for homosexuals, particularly in the African American community. And it's often used by those who prefer to distance themselves from terms associated with white dominant lesbian, gay, and bisexual communities. And I think it's really important. As I talk, I'm coming from a place of kind of white privilege, and where I sit in my positionality within the LGBTQ community. But I think it's important as we talk about questions is we are still focused on English language questions, and we are learning more, and we need to create a space for folks to identify and use more terms that are relevant to their populations and their communities, so that we can really understand how people define themselves. And so we'll talk a little bit more about that, but these slides do center in a lot of whiteness, and I think that's why I want to bring attention to some terms that are used that don't center in whiteness. Lesbian was defined in the video. Gay, I just want to bring attention to the fact that it's really become more of a broad term used by lots of different folks within the umbrella of lesbian, gay, bisexual, transgender, and queer. So it might historically have been used for men who have sex with men, but it really is used by folks of all genders at this time point. Bisexual, attraction to more than one gender, as compared to pansexual, where attraction in which gender is not a factor. My friend Erin said hearts, not parts, and I kind of adopted that for myself because I think that best describes my experience of the world as a person who does identify as pansexual. Straight, attraction mainly to or only to the opposite or other genders. Asexual is a sexual attraction to no one regardless of gender, but I think it's important to note that asexual is much more complex than we have time for today. So I encourage you to Google or look at the gray asexual spectrum or understand where demisexual or the split attraction model comes in to really understand different types of attraction that might be romantic, platonic, sensual. It's not always just sexual. And so I think asexual is much broader than what one term can capture, but it does give us information so that people can feel respected in their life path. Queer is a broad term that can be used very similarly to gay, but I think it's important to note that queer has been used to cause a lot of harm to community, and it's usually used as a reclaim word from folks within community, and it may still be uncomfortable for folks to hear. So switching from sexual orientation terms to gender terms, I just want to bring attention to non-binary as an umbrella term that is used to describe individuals who are not exclusively masculine or feminine. And it may include individuals who are agender, gender fluid, or genderqueer. And a non-binary person may or may not identify as transgender. They are not, they're not equal to each other. This is a map of states that have recognized non-binary identities and kind of what is required to update your license or other documentation. It's also important to note that it is allowable on people's passports. Agender is a term used to describe a person who does not identify with any gender or does not have a gender. So it's still an identity term, even if it is to say that I don't identify with any gender. For Two-Spirit, I want to use the words of Robert Kenta, who's from the Sluts tribe. This is from the Tribal Equity Toolkit. So the Sluts tribe is in the land that's now occupied by the state of Oregon. But I think it's important as a settler to these lands that I don't define this for myself. So I'm going to use Robert's words. Two-Spirit is a term in the English language that attempts to incorporate and honor the hundreds of ancient respective native language terms that were used for thousands of years within our communities, our culture, and our ceremonial life. Two-Spirit indicates an ability to see the world from both male and female perspectives and to bridge the world of male and female. Since the time of contact with Europeans, our Two-Spirit people and our societal beliefs surrounding Two-Spirit roles and contributions to our communities have been marginalized and stigmatized, resulting in marginalized individuals and groups of people within our families and our tribal communities. And I think it's important to note that this term was really coined at a summit of tribal elders from across this continent that met in Chicago in 1989. And so it's also been used differently by younger generations than older generations, but it is a term that should be used exclusively within Native populations. Transgender is a gender modality in which a person's gender identity rejects or expands beyond the gender assigned to them at birth. It is important to note that transgender is an adjective, not a noun, and it is a term related to modality, not identity. And we're going to spend more time on that in a minute. So explaining gender versus sex, I think it's really important that we separate these terms and understanding that gender is that identity, that experience of gender expression, attribution, how the world sees me, whereas sex is really a focus on reproductive biology, which is reproductive organs, genitals, but also hormones, hormone receptors, and chromosomes. Both are socially constructed. Gender is constructed by the roles in which society places on different identities and the expectations that accompany them. And sex is constructed in a social way as well, because the idea to categorize people and put people into boxes is something that might make life easier and it might be very useful, but it doesn't actually capture everyone's lived experience. And often sex is assigned by a visual exam of external genitalia at the time of birth. And it doesn't take into fact all of the other things that might be going on for a human that's in front of us. And so it's really important to understand the constructs and that this is humans putting ideas onto others rather than just being expansive to kind of those reproductive organs. And it's putting those folks in gut boxes. And so I think it's important, this is from George E.P. Box, but it's important, all models are wrong. We are going to miss some people in the way that we categorize or we ask questions, but some are useful. So while I acknowledge that sex and gender are social constructs, they are useful in giving us information in the work that we do. Because categorization is a social process. And we really want to understand that sex categories in the vast diversity of bodies, putting it down into just 3, male, female, and intersex, if you even have 3, most of us in our systems only have 2 category options of male and female, we're missing a lot of information. But we do this because it can help us understand people's bodies. It can help us understand who might be more likely to have a cervix and to make sure that we're ordering a cervical exam. But it's always important to think about what information are we losing or obscuring because we've collapsed to so few categories. Intersex is a term that may or may not be new to you, but it really is for people who occupy bothness, neitherness, and in-betweenness with respect to male and female characteristics of their bodies. And it's people whose bodies don't neatly fit into those categories of male and female. So it's an overarching term, but it's important to note that definition could apply to many people who are not intersex also. I think it's important to note that intersex can refer to all elements of sex and reproductive health, including chromosomes. And biologist Ann Fausto Sterling estimated 1.7% of people are born intersex. That's about the same number of people that are born redhead. So I think it's really important to think about how we don't want to just pathologize intersex bodies because they don't fit into our categories. Just because something's uncommon doesn't mean it is necessarily a disorder. So gender modality was a term that was first coined by Florence Ashley in 2019. And it really refers to how a person's gender identity stands in relation to the gender assigned at birth. So it describes the entire spectrum of experience, at one end of which is transgender, and the other end of which is cisgender. Cisgender meaning someone's gender identity aligns with their sex assigned at birth. Modality is really about position and not identity. So I think it's really important to think about that. So when we're asking questions about modality, we want to know someone's position in relation to their gender identity. So gender identity is referring to that innate sense of self, a person's current understanding that can change over time. And gender modality is referring to how that gender identity relates to the gender assigned at birth. And an example of this is a transgender man and a cisgender man both have the same gender identity as a man, but they have a very different modality. So if we're just asking questions about gender, what is your gender, both would respond man, and we would be missing information that could provide better care if we knew that someone was transgender. So we separate these concepts so we are better able to recognize and represent transgender people's identities in data to help us identify inequities that are specifically impacting transgender communities. Not collecting data about modality is actively contributing to the erasure of transgender experiences and is something that we need to be responsive to. So I'm talking about the Oregon SOGI questions. I know many of you are not from Oregon, but I'm bringing attention to the Oregon SOGI questions because we've done a lot of work in our state on collection of demographic information, and SOGI questions are demographic information. And it was recently recognized by the Center for Medicaid Services and encouraged to ask expanded SOGI questions. And the Oregon model was called out by CMS as a resource for expanded SOGI data collection. And so how did we get here? We didn't just come up with these overnight, and I certainly did not come up with these by myself. In 2018, we began really looking at how the demographic data collection practices that we had were contributing to erasure, discrimination, and stigma against LGBTQ+ people. And a committee was convened called the Sexual Orientation Data Collection Committee. And that committee really came together and drafted the original draft of questions, basically looking at intake forms from across the state and national best practices, and then conducted focus groups and then received feedback from over 400 individuals to shape these SOGI questions that take into account, for example, gender modality. And then we had this go through the legislature, so it is now a legal requirement for anyone receiving state-funded funding to incorporate SOGI data collection into our REAL-D, which is our race, ethnicity, language, and disability data collection for demographics for the state. And again, here's the reference from CMS, if you are in a place that is serves people who are on Medicaid, to understand how these Oregon SOGI questions can kind of be integrated into your practice. So what are the questions that are being kind of shared out with the world as far as the current guidance goes? I think one of the first things is, before you even ask the Oregon questions, is to really understand who's in the room and how that impacts the data. And so having a space, if you're doing a paper form where you're asking that information, or you're recording who's in the space when the data is being collected, because I think it's really important to not ask questions, or to ask the questions even when folks are in the room, but understand that there might be bias present, or people might answer differently based off of their own sense of safety. And it's important to respect that. And so we just want to understand what's going on, or if you're using an interpreter, for example. When you ask the questions, you always want to start with an open-ended question. So, for example, please describe your gender in any way you prefer, and then follow it up with the open-ended list. These are the list of options that were chosen by a community that we are using in the state of Oregon. I think one thing that's important to point out, that the goal of the way that our legislation is written around demographic data collection is we are hoping to be able to merge the REAL-D data, which is our race ethnicity data, with our SOGI data, so that we can start to collect information for other populations that would be better reflect the list options of their experience. So for example, if a person answers that they are a native Spanish-speaking individual of Mexican origin, and we get enough data over time in this open-ended format, we will be able to use that to then populate those response option boxes for anyone who answers that they are a Spanish speaker of Mexican origin down the road. So we're trying to collect the information because it doesn't exist right now to be able to populate this But we don't encourage translating, for example, gender fluid into multiple languages because it doesn't directly translate. It's better to ask the open-ended question and then have these boxes, which then help us categorize in a faster way to get information about disparities in our population. But knowing that language is constantly changing and we need to be capturing that space. And then following your gender question, you want to ask, are you transgender? Which is yes, no questioning. I don't know what this question is asking, or I don't want to answer. Then we follow that with sexual orientation. Please describe your sexual orientation in any way you prefer. Again, we start with same gender loving as an option so that we are not centering whiteness in our response boxes, but still having that space to collect the language that folks are using to describe their sexual orientation. And then we ask, and this is actually the order of questions, sex after. We want to ask people sex because we don't want to make assumptions based off of sex, based off of what's on someone's birth certificate, because people have different understandings of their bodies over time. And so we ask this question so people can answer female, male, intersex, or something else to get that more information, especially as people might have an expanded knowledge of their own reproductive biology. If you are in a space where you still have to collect sex for federal reporting purposes, or you have to collect things that need to match information that are on different forms, it's really important that you ask the questions kind of as is, but then have a space to say, is your current sex different from the sex that is listed on your documents? And you want to specify what document you need to know about. If you need to know about someone's driver's license, ask about your driver's license. If you need to know about someone's insurance, ask about insurance so that you can get that information, so that you don't need to be constantly asking or trying to problem solve why insurance claim is denied. So you have the information, but you want to make sure that you have a space where people are respected first. And I would just steer away from using terms like legal name, legal sex, and legal gender, but rather just refer to the document that you need, because we want to make sure that our healthcare environments are safe for all people. If you're in an emergency room or a federally qualified health center, we're not turning people away because of documentation status. So we really want to make sure we're not creating a space where it feels unwelcoming by the language that we use. So I'm going to do a quick role play and have Rachel come off of mute so you can see how this goes if you're asking the questions in real time. So I don't know. Rachel, I assume you're there. I can only see Amy's picture, but I'm going to pretend you're there.
Yes, I'm here.
Oh, perfect. And I'm going to pretend I don't know you. And we're going to kind of go through so people can see how this rolls out in real time. So, hi, welcome. My name is Dana. I'm going to be your provider today, and I use she, her pronouns. What name would you like me to use so you feel respected in today's visit?
My name is Rachel.
Rachel, before we get started, I have some demographic questions. Would it be okay if I ask you these now?
Sure.
Please describe your gender in any way you prefer.
I'm a woman.
Are there any other words you might use to describe your gender?
I don't think so.
I have a list. Would you like me to read it?
Sure.
I have girl or woman. I'll check that one because we kind of talked about that. Other options I have are boy or man, non-binary, agender, gender fluid, genderqueer, questioning, or something else.
No, I think woman is good.
And are you transgender?
What does that mean?
So transgender means that your current identity might be different than the sex that was listed on your birth certificate. So it also talks about your experience of gender, if you've ever transitioned your gender.
No, I don't think that applies to me.
Okay. And please describe your sexual orientation in any way you prefer.
I'm queer.
Are there any other terms you would use to describe your sexual orientation?
Yeah, sometimes I use lesbian or asexual.
Okay. And I have some other words. Do you want me to read the list?
Yeah.
I have same gender loving, lesbian, gay, bisexual, pansexual, straight, asexual, queer. So I heard you say lesbian, asexual, and queer. Are there any other terms that make sense?
No, I think that's it.
Great. And what is your sex?
Didn't you ask that already?
Well, we know the sex that is on your birth certificate from your medical record, but some people have more understanding of their kind of reproductive biology. So just want to understand, what is your current sex? Is it female, male, intersex, or something else?
Oh, it's female.
And that's kind of it. So, so that's kind of how you can go really quickly through it. And Rachel did a great job of kind of role modeling what people are mostly confused about the questions, which is most of what you get as far as when folks are like, I don't know how to answer that question. Sometimes it's just knowing kind of how to address that in the moment and move on. And I think it's also important to know if people are getting agitated by the questions or starting to get more emotional reaction to the question, it's okay to kind of pivot to a question that's not about demographics, to what brought them in today. And it's okay to leave questions blank or say, you know, it seems like these questions are bringing up a lot for you. We can move on. I just want you to know, though, that we are going to ask you these questions again, because these questions should be asked at least once a year in your practice environment, because identity can change over time. I'm going to really quickly, and I do mean really quickly, but I know some of you might be in a place to ask sexual orientation. I just really want to be clear about how SOGI questions are different than questions about sexual behavior. And so sexual orientation is about your emotional, romantic, or physical attraction to others, as compared to sexual behavior, which is which body parts are touching which body parts. And you never want to make assumptions based off of someone's sexual orientation about the behaviors that they're having. If you're in a role where you need to ask that, you need to be asking, you know, what body parts are touching which body parts. I think that's a really important distinction, that we aren't making assumptions about behavior based off of identity. And when it comes to asking SOGI questions, we're asking the SOGI questions so that person feels respected, sees that this is a safe space, as well as gives us information on how to better treat our patient population and kind of where we might have some missed opportunities. So if you are in a role where you do need to know more about anatomical sex for your patients, you should ask. So this is called an organ inventory. Epic and most electronic health records have a space to enter these data. Most people don't enter these data, but know that it exists as a page on your electronic medical record where you can just say, are you a person with breasts, a person with a cervix, ovaries, uterus, vagina, penis, prostate, kind of going through the list of things. In theory, depending on your system, if you say you're a person with a cervix, you should get health maintenance prompts for people that have a cervix, for example. So it ties those health maintenance prompts to the actual body parts, not what's listed in a gender identity, for example. Also, if you were asking about sexual health, it's always good to start out with are you sexually active? And if no, have you been sexually active in the past year? And then really asking about sexual partners and what types of people you're having sex with and what type of genitalia they have. So moving away from kind of this concept of risk and how many partners and the assumptions that we place on individuals based off of how those questions have been answered in the past, to really focus on where have you possibly been exposed? And if you've been exposed, we want to make sure that we give you the tools available that can help prevent disease. I want to just bring quick attention to the CDC's 5 Ps of sexual history taking, because if you are in this role, CDC, the Center for Disease Control, really focuses on partners, practices, protection from STIs, past history of STIs, and prevention of pregnancy, and really expanding that to be really patient-centered in our work. So when I talk about expanding the Ps of sexual history taking, I think I would like to start with preferences. What are your preferences around sex, but also what are the preferences you have for the words that you use for your body parts? You know, I can use medical terms such as vagina and penis or vulva. Is that something that's preferred, or do you have other terms that you prefer, such as front hole, when you're talking about your sexual practices? I also think it's important when we think about pregnancy, there's that underlying assumption that I brought up earlier that people have a desire to get pregnant. And rather than asking about pregnancy or prevention of pregnancy, what are someone's reproductive goals? Because people may have reproductive goals that are really important for you to take into consideration when you're talking about hormone therapies and things like that. And they are things that you might need to know more information about. So I wish I could make that a P instead, but I don't know how to turn reproductive goals into a P. If you have ideas, let me know. I also think pleasure is a really important part of sex. And I think as people age, we talk to men about erectile dysfunction, but we don't always talk to, or we talk to people with penises about erectile dysfunction. We don't always talk to people with cervixes about vaginal dryness, for example. And I think it's really important that we understand that pleasure is a part of sex and it's a part of life, and asking your patients or people in front of you, are you having the sex that you want? Is there anything that's getting in the way or any tools that I can have? Because we have medications for vaginal dryness. We have medication to support better hormonal balance and things like that, but you don't know unless you ask. And so I think it's really important to make sure that people are having the sex that they want to have, and that your ideas of pleasure and sex may not match the ideas of the person in front of you. And it's really important to make sure that we're always screening and addressing partner violence. Partner violence is significantly higher among LGBTQ populations than it is heterosexual and cisgender populations. And so I think it's really important that we're talking about that. And then also understanding that outness plays a role in sexual history or in sexual practices, and how publicly out someone is might impact the sex that they're having. And so we want to make sure that we're asking and respecting those boundaries that that person might have for themselves. And I just like this slide. This comes from a university site, but really making sure that we're being sexcellent. We are never trying to prevent sex. We are trying to prevent disease when we're having sexual history conversations, and making sure that that's really clear to our patients and the conversations that we're having with folks, that we're coming from a place of sex positivity. If you're in a role to collect data from minors, I wanted to spend a few moments on just how might you adjust these questions if you're talking to younger folks in your practice. It's important to know that we want to collect SOGI data from minors because we want to normalize people of any age thinking about and communicating about their identities. By asking these questions, we can give young people language to describe and understand their experiences, and it is a essential and important health intervention, which can be critically important during childhood and adolescence. So youth that are, especially gender minority youth who are accessing services or feeling supported and seen by respected adults, are less likely to have suicide ideation and completion. But you want to make sure that you are thinking about some key considerations if you are asking SOGI questions of youth. So that is, for example, is a parent or caregiver present? Are the questions age appropriate? And how are you respecting autonomy? So understanding that parent caregiver presence can impact the way questions are asking or questions are being answered. It's important to consider who's in the room, but for anyone, but especially for minors. So minors may be reluctant to provide SOGI data if they have an unaware or unsupportive person in the room with them. And you want to use similar privacy protocols that you would in discussing any minor's sexual behavior, substance use, or mental health. So you are already doing this. SOGI questions should come under that same kind of privacy protection protocols that you're already using in your practice. If you're collecting data from the parents and caregivers, it's important to know that the data might be less reliable, but that kid is watching. That kid is seeing what's happened and knows that at a time that they might want to disclose identity, that you're a safe person to disclose to. So we're not, regardless of whether or not the data is reliable or good, it's still important to ask. And parents are only going to or caregivers are only going to reliably report on assigned gender or assigned sex at birth or what their child has told them. And for young children, you might want to just ask, what should we know about your child's gender if you're asking for that information from a parent? Caregivers may misrepresent SOGI identity or SOGI data for a host of reasons, which could include a fear for their own child's safety. They could be unaware or they could be unsupportive. And so you don't know what those reasons are, but you want to make sure that you're creating the space and making sure that if there is something that comes up, you can make sure that the people get access to the tools that will best support their healthcare outcomes. As far as age appropriateness, gender questions can be asked at any age, but maybe children under 12, we should really want to make sure we're asking simplified questions for folks. Sexual orientation usually gets asked at the onset of puberty or in adolescence. And so while children may become aware of romantic or sexual orientation from a very young age, we don't actually recommend asking about sexual orientation prior to that onset of puberty. We use 12 as a proxy for adolescence. And there's been good data that any adolescents over age 12 can use the adult SOGI data collection tools. And there's great data validity. So just make sure you might get some unexpected answers and that you're prepared for that. So if a kid says they're a unicorn, they're a unicorn. And we're going to use mirroring back and forth of what people say. Because we see SOGI questions for youth really as that health intervention. And it's a way of really laying a foundation for positive interactions with the healthcare environment throughout the course of life. It's also important to recognize autonomy. So there might be some inherent risks in collecting any demographic data, including SOGI data, but not collecting it contributes to the erasure of sex, sexual, and gender minority or SSGM individuals. When you collect SOGI data, you're giving a person a choice of whether or not to provide the data. They may participate in their representation or not, but you have not taken it away from them as the institution. And so not collecting that SOGI data is really taking choice away from individuals. So here's a question that you could use as a gender identity question for minors under age 12. Again, over age 12, you're going to use the same questions as the adults. And you're going to add sexual orientation. But if folks are under, you just want to say, are you, check all that apply, a boy, a girl, both, something else. I wanted to end on just some kind of ways of using affirming language, and how we use names and pronouns can make a really big difference. As a person who is cisgender, I think it's really important that I'm always cognizant of using names and pronouns, and making sure that I'm trying to be respectful at all times. And so if you're ever unsure, I think these are just kind of some prompts for you to really ask about it. If you're ever unsure, I would like to be, it's good to say, I would like to be respectful. What name and pronoun would you like me to use? If a client's name doesn't match insurance or medical records, could your chart or insurance be under a different name? What is the name on your insurance? If you're accidentally using a wrong pronoun, you want to quickly correct yourself. I think it's really important, though, that you don't make someone feel like they have to make you feel better for making a mistake. So be really quick, he, I'm sorry, she, and move on. It's also important to be like, thank you for correcting me. If someone ever corrects you and says, actually, I use a they pronoun, make a note, make the note, and make sure that you let them know that you're going to get it right next time. You're going to remind yourself. And it's really important to know that when folks are correcting you, that means that they see you as a safe and trusted individual to show their authentic self. And then you want to make sure that you are respecting that. I wanted to show a video before I tell you your pronoun practice. Ha! It's going to work. It's going to be magical. Because again, I want you to hear from folks themselves about how important pronouns are.
Just because I may present more femme doesn't mean that I'm any less they, them.
You know what, that thing where you're eating a meal, but you're not really eating a meal, you're just kind of picking at food on the counter. My family and I were doing that one night, and I just kind of looked at them and said, hey guys, I'm non-binary. I don't have a gender.
In my opinion, gender is a universe. It is a broad spectrum of planets and stars and sky that truly cannot be contained into a binary.
My pronouns are they, them, theirs, and that's a non-negotiable. And they were all kind of like, okay.
I think one of the main reasons pronouns are so important is because other than our name, it's one of the main ways that people identify and call us.
My pronouns are personally very important to me. Growing up, enculturated into kind of a system that really subscribes to toxic masculinity, I was always uncomfortable with being called dude, what's up, man. I was so bad at dapping people up, like, how like guys like do that whole like that thing. I was so bad at that, and it just I felt very alienated every time someone would do that to me.
So when someone identifies with a pronoun, they're essentially taking their little piece of that broad universe and identifying with that. And so in using their correct pronouns, we're validating that yes, you are right in your identity and you are important and we're respecting you.
Coming into terms with my gender queer identity has been one of the most challenging but also rewarding things that I've done.
Laverne Cox kind of famously said, misgendering a trans person is an act of violence. And it is. It's an act of psychological violence. It's a denial of somebody's personhood and a complete refusal to acknowledge their identity, whether intentional or not.
And so it is something that is entirely wrapped around our everyday lives. So just walking into a restaurant and hearing someone say she, will happen within 2 seconds of me entering, which doesn't happen about any of my other identities. They're not going to be like, oh, you straight person, that doesn't happen. But automatically someone will make assumptions about gender which translate into pronouns, which mean that I will hear over and over again people saying something about my identity which is false.
I think a lot of people associate expression with identity, and sometimes that's not the case. Oftentimes I'm in situations where I'm not the most safe being able to express my gender identity, and in those cases, even in those instances where I'm wearing basketball shorts or sneakers, you can't take my gender identity away from me because that's mine and not yours.
So many different options for who you are and how to define that. So when someone chooses a personal pronoun that they identify with, using that pronoun is a form of respect and a form of validation that, yes, this is your rightful identity, and I will respect that.
And I know personally when I get misgendered, by strangers it's one thing, but it's especially painful when it's people who are close to you. So when my parents misgender me, it's a knife in my heart because they're the people whose opinions matter more to me than anybody else's.
And not knowing how to combat it. It is constant, and it is such a prevalent part of our society that being misgendered happens countless times in a day, and that builds up really quickly, and it can really be difficult for a person to hear over and over again because it invalidates your identity over and over and over again.
Pronouns are important because they are the smallest and easiest way that you can acknowledge somebody's identity.
And I also don't like that people call them their preferred pronouns, because it's also not a preference. It's who they are. You need to use those pronouns. It's literally an extension of my arm or my leg. It's just as a part of me as a vital organ. My identity, although you can't see it, still needs to be validated just as much as you would validate the fact that I have 5 fingers or 5 toes.
I hit escape too many times, but it should be okay. So after that video, what I usually do if I'm in in-person training or I have more time is I really encourage folks to just sit and actually practice using gender neutral pronouns. I think it's, there's something on my screen. It's just YouTube letting me know that they want me to keep showing that video. Hopefully you can see my screen okay. So I'm going to give everyone a homework assignment, because I think it's one thing to go to a training like this and learn new information. It's another thing to actually apply it into the work that you're doing. And so I think it's really important that you take this event. If you have time in a staff meeting to show that video, but then take turns telling each other or group something about someone in your life, but use only the gender neutral they, them pronoun. And if you feel really comfortable with they, them, and you're familiar with they, them pronouns, you can try some other pronouns such as they, zer, or ze, them, or also try talking only using the person's name. And the reason why this is important is because, as that video says, it's one small thing that you can change even today that will make a positive impact on patients' lives. And I think we need to think about the way that we refer to our patients when they're in the room and when they're not in the room. So when you're writing your chart notes, what name and pronouns are you using in your chart notes? Patients have access to those chart notes and are seeing themselves being misgendered in chart notes countless times, and it's invalidating of their identities. And so really making sure that the way you're referring to somebody is in a way that is respectful, so that they can be respected even when you're not in the room. They, them has been a singular pronoun for a really long time. You've been doing this. You may not realize it. When you say, where did Rachel go? Oh, they'll be right back. You're already using it, but I think it's being more cognizant and being more mindful of how language has a lot of power in the work that we do, and making a really safe space for folks. So I want you to do this exercise in your practice, or try having a conversation where you're using a gender neutral pronoun, to really think about how you can shift kind of your way of thinking. And so here's a list of more pronouns that you can use to reference, if that's of interest to you. So we have these kind of pronouns and just examples of how to use them. And so these will be in the slides that you will have as a reference, because I think it is really important. And it's this one thing that you can do starting today that will have a big impact on your patients, and feeling affirmed in your space. In general, when you're using identity terms, I think it's really important to listen, understand, and mirror the terms that the patients are using to describe themselves. And keep in mind that some people don't like to use any terms at all to describe their identities. Some people may not use a personal pronoun, and as appropriate, you might use that person's name or another chosen identifier. People may have different ways to identify in different settings. I think this is really important to think about how they identify when they are in a session with you as compared to at work or in their personal life. And then really make sure that you're taking that time to ask someone, how would you like to be referred to in my chart notes? And making sure that folks are okay with that, and understanding confidentiality in the work that we do. Who's going to have access to that chart note, and how do they want their identity reflected in the information? Because I think it's really important to know that people may choose not to disclose because of safety or other concerns that they may or may not have shared with you. Doesn't mean you don't ask the questions, but you really want to respect a person's autonomy and how they want to be represented in their paperwork. And that some people may not want to choose a label, right? And so they might not want to choose a label because they don't want to be put in a box, or don't want to perpetuate a system that isn't serving them at this time, because our systems are not serving all LGBTQ plus people well. And after coming out, sometimes changing labels is stigmatized, and they don't want to be further stigmatized in various settings. At the same time, people might choose a label because they want a sense of community with others who feel the same. They might demonstrate pride, eases communications, and it might be a way of being able to access additional resources. I put this kind of other quote just about sex positivity. It means you don't have to be ashamed of how you do or do not define yourself. It's just creating a space for people to come as they are and live their authentic lives. So again, here's this model that I kind of breezed through in a lot of different slides really fast, but really taking time to really think about, what am I asking? How am I asking? And how does language change over time? So sexual orientation is that romantic, emotional, physical attraction. Gender identity is that internal sense of self, how someone feels in that moment about who they are as a person. Gender modality is their experience of gender and that position of where they're at in that spectrum of cisgender to transgender. Gender expression is how the world might see a person, or how a person might dress to portray either a masculine or feminine characteristics, or even androgynous characteristics. And then really thinking of sex not as what's written on your birth certificate, but really thinking of sex as, what are those reproductive organs that a person has? And if we're collapsing down to so few categories, making sure that we're cognizant of what we might be missing. So with that, I have some resources that I want to bring your attention to. So this is our website, and I bet Rachel can put it in the chat because Rachel's magical that way. This is our website. This is just a screenshot of it, but it's constantly being updated as we come up with additional tools to support the implementation of SOGI data collection in Oregon. So we have glossaries of terms in Spanish as well as English. We also have Oregon's guide to the SOGI demographic standards for minors, specifically if that's something that you're working in, to have that resource. But we're also uploading videos, other resources, crosswalks to how do you map the Oregon SOGI questions to federal data reporting and those sorts of things. So it really is a tool. The Oregon Health Authority also has a website that's being updated in real time as we get through our rulemaking process and additional resources. So this is constantly being added to, but those Oregon SOGI crosswalks is definitely how you report and translate the Oregon questions into HRSA questions, for example, and the coding behind it, depending on your role. So with that, I want to acknowledge that my presence here was funded by the Mountain West AIDS Education and Training Center that is supported by the Health Resources and Services Administration. I wanted to make sure that we had time for questions because I threw a lot of content out at you. So I'm going to stop sharing. Again, you will get access to the slides, but I want to make sure that we have a space for questions and answers for you to have time to write in your questions so that we can kind of answer that in real time. And I'm just wondering, Rachel, if you have anything that you want to bring my attention to as I open up more screens and not share slides.
Yeah, so one question that we have that we wanted to make sure we answered live is, our organization is working on a new initial assessment and are aiming for something that is minimally intrusive. Do you have examples of SOGI collection for initial assessments?
Sure. So I think one of the questions that I would have kind of for this question, let me put it that way, is really thinking about why is it that you want to have something that's minimally intrusive? Because SOGI questions should be treated like any demographic question. So if you're going to ask about race, ethnicity, for example, we should be adding sexual orientation and gender identity as part of those kind of routine questions because they're not intrusive questions. Now, questions about what body parts we're touching, which body parts are probably a lot more intrusive. And I think that's really where we want to separate why we're asking SOGI questions from behavior questions. I think that's an important piece of that. I think the other piece is to know that these questions that I talk about in Oregon are being asked across our state in really rural areas, which I think is an important piece for folks to also kind of be aware of. Is this is not something to just focus on urban centers. In fact, I think it might even have more of an impact on asking these questions and creating spaces for people to be their authentic self in more rural areas. And I think it's just really thinking about how are you going to respond if someone were to get upset? And so I think questions are really thinking about what training can you do for staff rather than trying to make the questions any more simplified than they are. Does that, and I don't know if that answers the question because it's this kind of random question and answer. But I think if you wanted to make it even more simple, I think you could just have it as open-ended questions and not have the check boxes. I also would say titles is something that is a question that is coming up in the chat. Like, do you use, if you've seen people have written in like the MX or mix instead of Mr. or Mrs. or Ms. I think it gets to the question of why are we using titles, and what does that really reflect, right? So if someone using a Mrs. title, for example, is that saying that they're married? Why do we need to know that? And oftentimes we have a habit of saying, welcome in, ma'am. Happy to meet you, sir. We're constantly gendering people. And I would encourage us getting away from the habit of using titles in general and calling people by their name or whatever they would like to be called. So what name would you like me to use? How can I show you respect today? And depending on what they say, reflecting and mirroring that language back rather than putting in some of the titles. So there's another kind of question that popped up. I sometimes run into challenges when I present all these options to my older patients. Some are overwhelmed and confused by all the options. Do you have recommendations for discussing SOGI with older patients? I don't know if Rachel's going to be able to find the guide for asking questions of older adults. It does exist, and it came out like last year. So maybe Rachel will do some fast Googling to find that resource, because there is a resource, and the resource still says to ask gender modality as a second question. But I think it's really, again, focusing on having the definitions ready so you can say, what am I asking and why, right? So if you say, what is your sexual orientation? And someone says, why are you asking me that? What is that? It's important to understand what a meaningful relationship is for you. And we're asking about who are you romantically or emotionally attracted to. And if they're like, I'm married, that's what a lot of people who are really old might say. It's like, I hear that you're married, but married isn't a sexual orientation. So are you having the relationships that you want to be having? And do you identify as anything else? And if you're attracted to someone of opposite genders, that might be heterosexual or straight. Does that word apply to you? And so I think having those definitions that at the ready can help with those conversations, because a lot of it comes from a place of confusion when you're asking the questions. And so I don't always read the whole list, if that makes sense. Because you're right, that list, people are like, genderqueer, gender fluid, same gender loving, like you keep going on to all of these terms. I think it can get overwhelming. But there is a guide that Rachel will find. If we don't find it right now, we'll make sure that it gets sent out with the slide deck for this presentation. The next question is, I'm a part of a state hospital system and constantly have to correct coworkers about pronouns, which I'm aware many do not use that term, but my organization is literally the dark ages. Yes. How do I have better conversations about this, especially for our trans patients? And so I think pronouns is really important. And I think it's also important to recognize that we don't want to force people to identify or come out, in the sense that sometimes when people have their name badges where you have pronouns on it, so people have, I would have Dana and I would have she, her, making it a standard on everyone's name badge means that you're then forcing your employees and staff to have to identify in a certain way in that space that they may or may not be comfortable with. So it should always be optional if people want to, as from a staff place, identify their pronouns. And then those that are choosing to put their pronouns on their badge or put a rainbow on their badge, they need to be comfortable having conversations with patients so that it can be a signifier. So I never say everyone in your institution should have a rainbow on their badge or however people, if they have a lanyard or something like that. Because if everybody has the rainbow, then you don't actually know who the safe people are. And people are all in different stages of learning, and that's okay. But you need to make sure you have one or two folks that are visibly present to be a resource for folks. I think that's a really important piece. And then having a culture where you can hold each other accountable, where you can say, as a person that might be a mental health provider to the emergency room clinician, hey, I believe that patient uses this pronoun. I would steer away from using conversation around preferred pronouns, even if it's in your electronic record. Start to train that out of you, because a pronoun is who a person is. It's not a preference. And so making sure that we're kind of using the language of chosen pronoun, that patient's chosen pronoun is they, them. And when you say that, you're also making it like, this patient says they want to be called this. if that makes sense. And so it's a cue to that other provider, but you need to work in a culture of accountability, which can be really challenging. I also think, we have this thing like, oh, it's so easy. You can ask these questions every time you see someone new. If people are coming in for a broken leg or for an acute crisis, you might need to deal with that crisis and ask these questions at a later time. And so just giving yourself that grace to make sure that that person's in a place to talk about demographic questions. But I would not treat SOGI questions as anything different than any other demographic questions you would ask. Any more questions?
Yeah, there was another one in the chat. Can it be invalidating to avoid using pronouns altogether and only using someone's name, like you mentioned, kind of towards the end there?
Yeah, I think you want to ask a person how they want to be referred to, right? So, and I think the other thing is this is for all patients. It's not just for transgender patients. There are a lot of people who have a name, like my brother's name is James on his birth certificate, but everyone calls him Jim and it drives him crazy and he doesn't want to be a Jim, right? Like, I think it's okay to realize that people have names that they like to be called to feel respected. And that's not about sexual orientation and gender identity. It's just what people want to be called. And so routinizing that and then saying, hey, if I'm doing your chart note, how do you want to be referred? Should I just use your name or can I use a pronoun? What pronoun should I use? And making it really routine in the way you ask those questions, I think is really important, but really recognizing this concept of universal design. I'm talking from a queer lens as a queer person, but a lot of these tools will make a more inclusive space for all of your patient population, not just those who might have lived experience more similar to mine. Did I answer that, Rachel?
I think so. Let us know in the chat if not. There's also just some conversation about the pronouns video that we just watched, and someone mentioned they got lost in it. I think it was just a lot at once. So I don't know if you want to just share like a little debrief or some main takeaways from that.
Yes, I think some main takeaways from that video is just really understanding how it's really important for folks to be seen and heard, and that people make assumptions about identity constantly as individuals walk through life. I think an example I use is where you're getting bombarded by these, for lack of a better term, microaggressions about gender on a daily basis. So I was in a hotel in a really big city. It was a really nice, fancy hotel. It was like a Hilton or a Sheraton, like a big chain hotel. But they wanted to be kitschy and boutique. And so they had, for the little sign you put outside your door that says do not disturb, they had one side was pink and it says I'm checking my makeup. And then the other side was blue and it was like I'm adjusting my tie. So walking to my hotel room, I was bombarded by pink and blue and reinforcing this concept of gender, just trying to get to my hotel room and being just really, and I felt overwhelmed as a cisgender person about, oh, so that happened. And then this person might go somewhere and then another assumption's made. And those assumptions build up over time. And so I think what Rowan in that video was talking about is all these different invalidations that are happening over time are causing a lot of stress and anxiety. And having one person break up that kind of monotony of invalidation and saying, hey, how do you want to be treated today? Or I'm really sorry that I made that mistake. I'm going to correct it in the future, is a moment of taking a deep breath and helping someone really regulate and say, oh, this person sees me. And there's a lot of really great data, especially among young people, that if they have one supportive adult in their life that sees them as their authentic self, they are less likely to have suicide ideation and completion. But not only that, LGBTQ youth with at least one supportive adult have better health outcomes than their cisgender heterosexual counterparts. And so having that support and community is actually one of the most important things that folks can have. And creating space for people to share that community or build those relationships is really valuable. So that's where your gender and sexuality alliances or GSA clubs come in. That's where other things can come in. But understanding that pronouns is one thing that you can do to not be repeating the microaggressions that are happening, both verbally, but also just in the way our society is structured. And I see there's another comment just about kind of people using terms like miss. And one thing is like, I hate being ma'amed. It makes me feel so old. I lived in Louisiana. Like, I get it. And I also think there's a lot of layers to the language that we use. And so just really understanding kind of how we can be more neutral in our healthcare spaces is not being disrespectful. I think that's a really important piece. And I see someone raise their hand, but I don't know how that works. I'm going to admit that. So you might have to put it in the chat even if you raised your hand.
There's another one that just popped into the Q&A.
Yeah. Oh, into the Q&A. I didn't see that Q&A. One second.
I can read it.
I'm like looking at the chat. Go for it.
Yeah. What about youth in treatment? To be transparent and respectful, yet also maintain confidentiality. It's difficult to make the decision to use appropriate pronouns and gender references if the youth client has opposing ideals with their parent or parents, and they may not or don't want the clinician to inadvertently out them or violate confidentiality for our youth.
Totally. And I think that's where ideally you have a space to talk with the youth without their parents present. When you're asking about sexual history, and this is something that is routine. I think providers can say, I routinely talk to my patients, by themselves to ask any questions about kind of mental health. You're already doing that. But when you do that, you can ask really specifically, your parents are going to have access to your chart notes. I want to make sure you feel respected in this space. Is there a name or pronoun you want me to use in this space when we're alone versus something you would want in your charts or something you would want me to use with your parents? And then you're saying to that kid, I recognize that this may not be right for you at this time, but I want your safety to be most important and what you feel most comfortable with. But you've still taken that moment to show that kid, I see you as you. And this was a lot easier with paper charts when you could put it on a sticky note. I'm going to be really clear here. I love sticky notes. I used to work in outpatient drug and alcohol treatment, and we would have notes on sticky notes about names and pronouns we would use like in a group setting, which might be different than in other settings. And so I think figuring out ways and systems, this is not all of your patients. There's going to be a handful of patients. What can you do to make sure in your team huddle in the morning that that patient is respected? I think is really important. So the other kind of question that's coming up in chat is, I have college students ask me not to bill insurance or change their diagnosis to something vague like an adjustment disorder, so that it doesn't reveal everything. And I think, again, it's when it comes to diagnosis code, I am not a clinician, so I'm not going to address kind of diagnosis codes and your own charting. I do think, though, it's really important to be mindful of who has access to records and understanding that confidentiality has its limits. And so being really clear about what's going to happen. Now, at the same time, you're going to have your own systems for how folks are billed, and different states have different laws and rules about, especially when it comes to reproductive health and access to mental health services. So a state like Oregon, Medicaid, don't quote me on this, but I believe kids over the age of 15 don't have to have parents have any access to their medical records. So that college students in Oregon don't have parental access to medical records. I know that for sure. I believe it's at 15 that goes live. So, but depending on the states you're in, because I know some of you are in states where that's not the case, where you don't have those protections, I would be really transparent with folks. And understand it's not the best option, but it's the reality. I definitely want your information and your feedback on the evaluation. So yes, SAMHSA wants it too, to prove that we were all here. But I also think this is a great opportunity for you to list what would make this better. It was a lot of information, but also if there's things that are missing or things that you would want to do kind of more exploration of, the evaluation is really a place to kind of write down your ideas about what you'd want to see next. So do take the time to do it. It's important. I will read it, not just SAMHSA.
Thank you so very much. Everybody is chiming in. This was a great presentation, so much information. And really quickly, I know there has been some stuff in the chat and the Q&A regarding certificate of attendance. You will be receiving one within a couple weeks after this event. And it's been put in the chat too. You'll automatically be sent it, so no worries. Thank you so much, everybody, for being here. And thank you to Dana and Rachel for your expertise. So appreciated.